prostate is the largest of the male accessory glands found in the reproductive tract. It's approximately 4 centimeters in size and located inferior to the bladder and anterior to the rectum. Surrounding the urethra, a tubular tract that carries both semen and urine. Its primary function is to produce prostate fluid, which makes up 30% of the seminal fluid. It assists in transportation and nourishment of the spermatozoa with enzymes and nutrients during ejaculation. Prostate cancer is currently the 6th most common cancer in the world, the most common cancer diagnosed in Australia, and the most commonly diagnosed cancer in males. By 2020, approximately 25,000 men are expected to be diagnosed with prostate cancer, nearly 6,000 more than in 2015. It is also expected to claim over 3,300 men's lives each year, representing 12% of all cancer deaths. The mean age of men affected by the disease is 68.4 years old, with 85% of new cases being diagnosed in men over 60. Prostate adenocarcinoma is the most common type of prostate cancer and is a mutation of the glandular epithelial cells. It's typically a slow-growing malignant tumour that many patients can live with until they die of other natural causes. Patients diagnosed with prostate cancer have a 95% chance of surviving greater than 5 years. However, survival is dependent on tumour staging score. If left untreated, it can metastasize via the circulatory and lymphatic system, resulting in organ failure or death. Rare types include prostate sarcoma, small cell carcinomas, neuroendocrine tumours, or transitional cell carcinomas. However, these are considered as extremely rare and are typically more aggressive. As the prostate tumour grows, it encroaches on and blocks the prostatic urethra, creating issues such as the need to frequently urinate, difficulty urinating, feeling of incomplete urination, hematuria, hematospermia, fatigue, shortness of breath, rapid heart rate, pale skin, erectile dysfunction and bone pain in association with metastases. As men age past 50, the chance of developing prostate cancer increases significantly. 1 in 7 men are likely to have prostate cancer over the age of 75 and 1 in 5 men over the age of 85. Men with a family history of prostate cancer have an increased risk of developing prostate cancer, with an even further increased risk if the cancer was diagnosed earlier in their relatives' lives. Genetic mutations in the breast cancer 1 and breast cancer 2 genes also increase the man's chance of developing prostate cancer, as well as people living with the Lynch syndrome. Some evidence suggests that lifestyle factors like a poor, unbalanced diet, high in animal fat, and also lack of exercise increase the risk of developing prostate cancer. Studies in America and the UK also suggest that men of dark ethnicity are also more susceptible to developing prostate cancer. The use of industrial herbicides have also been linked as a contributing factor.
The pathway for diagnosis of prostate cancer begins with both the digital rectal exam and PSA blood test. Both tests can be performed as a form of standard health check for men of high risk age, but are mainly utilised at the presentation of men with urological symptoms equivalent to that of prostate cancer suspicion. A palpable change in the structure of the prostate during DRE or elevated PSA levels by age often lead to further in-depth investigation with imaging modalities within a diagnostic objective. The initial imaging investigation for prostate cancer normally involves a multiparametric MRI, known as an MP-MRI. MP-MRI imaging is a relatively new technological advancement that is now greatly utilised as a main form of initial prostate cancer diagnosis and to direct biopsy. MP-MRI uses 4 separate image projections to construct an image of the prostate with increased sensitivity and clarity. It allows for the visualization of growths and irregularities within the prostate gland itself, as shown in figure 8 above, allowing for a greater sense of localization and to assist in guiding of biopsy should it be required to further investigate such irregularities. These images are often used in conjunction with a transrectal ultrasound image of the prostate, which involves the insertion of an ultrasound probe into the rectal cavity to gain greater access to the prostate gland itself, and hence allow for further localization of such irregularities and assist in the further guidance of biopsy. After a biopsy is conducted, if it returns a positive sample for prostate cancer, the utilization of imaging is moved into more of a staging and management objective rather than one of diagnostic value. This is usually performed using both PET-CT imaging and bone scans. Bone scans are utilised to investigate any appearance of skeletal involvement in the spread of cancer. A bone scan with severe skeletal metastases from a prostate cancer diagnosis is shown in Figure 11. Hybrid PET-CT images utilising an array of radio tracers such as gallium-68 PSMA are also used to gain a greater understanding of the severity of spread of patients' prostate cancer, allowing for a highly sensitive visualisation of cancer spread into soft tissue physiology such as lymph nodes, as seen in Figure 10. A standard chest abdo-pelvis CT scan with or without contrast can also be performed at this stage of the imaging pathway for a staging method, but is now not as regularly utilised due to advancements in PET-CT hybrid imaging, allowing for a diagnostic CT image to be acquired at the same time as PET imaging. A standard chest abdo-pelvis CT would further assist in the visualisation of metastatic spread of prostate cancer into structures such as the lymph nodes and skeleton, allowing for the construction of a TNM score, which is used as a form of disease grading. Depending on the findings of these staging and management-focused studies, a drastic effect can be played on the patient's prognosis and subsequent treatment plan. When used both before and after treatment, an increasingly sensitive and reliable understanding can be formed regarding the success or failure of such treatment to improve or have no effect on the patient's prognosis.
A PET scan using 68 gallium prostate-specific membrane antigen, or PSMA, is a non-invasive diagnostic imaging technique commonly used in prostate cancer imaging. Indications for this scan include localization of recurrent prostate cancer, primary staging in patients at high risk for prostate cancer before surgery or external beam radiation, and for staging prostate cancer before and during PSMA-directed radiotherapy. 68 gallium PSMA PET imaging for prostate cancer has been developed to address the limitations of prior imaging using 11-carbon choline, which was found in numerous studies to have a low sensitivity and specificity, especially in the presence of a low PS4 level and/or high Gleason score. 68 gallium PSMA is generator-produced, a positron emitter with an 89% yield, and has a physical half-life of 67.63 minutes. PSMA is a transmembrane protein which is present in all prostate tissue, though increased expression of this protein can indicate malignancy of prostate cancer, as well as other cancers, such as colon, esophageal, and thyroid cancer. 68 gallium PSMA localizes by receptor binding to prostate-specific membrane antigen ligands and is excreted into the urine via glomerular filtration. The normal biodistribution of 68 gallium PSMA includes the lacrimal glands, liver, spleen, nasal mucosa, bowel, and bladder, as well as the kidneys and salivary glands, which exhibit the highest radiopharmaceutical uptake. This biodistribution is evident in this image, which shows uptake of 68 gallium PSMA 1 hour post-injection. Tumours of prostate cancer have a higher tumour to background ratio compared with normal tissue. There is no patient preparation prior to a 68 gallium PSMA PET scan, as patients are not required to fast and do not need to cease taking any medications. However, it is recommended that the patient be well hydrated before and during the uptake period, with approximately 500 ml of water at 2 hours before the scan being recommended. Patients should also void before the scan to decrease uptake by the bladder on acquisitions and to avoid false positive findings due to uptake by the ureters. 68 gallium PSMA is intravenously injected through a cannula as a bolus with an activity of 1.8 to 2.2 megabecquerels per kilogram of body weight. A 60-minute uptake time should be allowed before the acquisition, and additional imaging at 3 to 4 hours can be implemented if required due to better lesion detection. There are no restrictions to patients during this uptake period. The patient should be positioned supine on the scanning bed with arms raised above their head. A 68 gallium PSMA PET scan involves a low-dose CT scan followed by a PET acquisition. The CT acquisition, which includes the topogram, should be acquired cranial caudally from the skull base to mid-thighs. The PET acquisition should then be acquired in the opposite direction, going from mid-thighs to base of skull, in order to image the pelvis while there is a decrease in activity in the bladder due to the excretion of 68 gallium PSMA. The PET acquisition should be acquired in 3D mode at 2 to 4 minutes per bed position. One study reported a sensitivity, specificity, positive predictive value, and negative predictive value of 76.6%, 100%, 91.4%, and 100% respectively for lesion detection in 68 gallium PSMA prostate cancer imaging, and therefore has significant diagnostic value. 68 gallium PSMA PET imaging has started to be used more often in prostate cancer imaging and has the potential to become an integral part of standard nuclear medicine practice. In addition, a nuclear medicine bone scan is effective at detecting bone metastasis from prostate cancer and therefore plays a vital role in the staging of prostate cancer due to its tendency to spread to the bones. Bone scans can detect metastasis in 80% of patients with no tumours and bone pain, and thus is a significant imaging technique for prostate cancer.
Theranostics, a combination of a predictive biomarker and a therapeutic agent. Think of PSMA as a magnetic docking site. It can be chemically linked with, for example, a beta emitter like lutetium, which is a small molecule peptide with a high binding affinity for PSMA. This gives a high radiation dose to the cancer cell. After binding to the active centre, linking the radioligand to the antigen PSMA, PSMA is internalized and retained for the killing effect. Its expression is further increased at advanced stages of cancer, and it is overexpressed in 90 to 100% of metastatic castration-resistant prostate cancer. Who is suited for therapy? Patients who have failed to respond to treatment like hormone therapy, chemotherapy, or external radiation therapy. If the patient has had prostate cancer with significant expression of PSMA on cell surface determined in imaging, and if PSMA is expressed in some non-cancerous tissue like the salivary glands and the proximal renal tubular cells, these tissues need to be fully functioning. Why is PSMA an ideal target? It can selectively target multiple metastases without significant damage to normal tissue. The radiation emitted only travels a short distance, sparing normal tissue. This can be compared to radiation therapy. PSMA's expression is independent of the use of taxane-based chemotherapy, making imaging advantageous because it doesn't have that flare effect. Treatment like chemotherapy is often toxic and negatively affects the patient's quality of life, whereas this treatment has caused little complaints by patients. PSMA can be present in solid tumours in the colon, kidney, bladder and breast, which makes it a potential tool for future theranostic applications outside of prostate cancer.
When deciding what radionuclide is best for therapy, ideally, emission characteristics of the radionuclide should match the lesion size and volume to be treated to focus energy within the tumour, sparing surrounding tissue. Lutetium-177 has desirable physical characteristics that has caused it to gain popularity as a therapeutic radionuclide. It is a medium energy beta emitter and has a maximal tissue penetration of less than 2 millimeters. The shorter range provides better irradiation to small tumours compared with yttrium-90. It is reactor produced and also emits low energy gamma rays, allowing for ex vivo imaging that can give further information about tumour localization and dosimetry. The image shows typical biodistribution 20 hours after injection. The salivary glands, kidneys, and tumour lesions show highest uptake. Patient doses can range between 3 to 8 gigabecquerels and is determined by a range of factors, including disease burden, renal function, and patient weight. Typically, lutetium PSMA is administered via slow intravenous injection in a volume of 5 mL, diluted with 0.9% sterile sodium chloride solution, followed by a flush of the sodium chloride solution. Due to the excretion pathway of lutetium, it is recommended that the patient is well hydrated pre and post administration of the radionuclide therapy. The reported toxicities of this therapy have been of low grade in all studies published. However, common side effects can include dry mouth and xerostomia, fatigue and nausea. In Australia, this therapy is administered in an outpatient setting with no significant symptoms at the time of injection. Lutetium is renally excreted within the first 48 hours post-injection, and due to this, the patients, the staff, and the family of the patients need to be given instructions in managing potential radioactive spills, and patients must stay within the department for 2 to 4 hours post-injection for observation and for measured radiation levels to decrease. As for radiation precautions, to the patient and family caregivers, our PANSA recommends that the ambient dose equivalent rate at a distance of 1 meter from a patient who is undergoing treatment with a radioactive substance should not exceed 25 microsieverts an hour at the time of discharge. As PSMA is expressed with relative density in salivary glands and kidneys, biological effective dose to these organs are an important consideration when deciding dose. The aim of the therapy is to reduce serum PSA levels, decrease pain, and increase quality of life. Though there have been numerous trials and published studies, the variety of treatment regimes, i.e. doses and the number of doses given, makes interpretation of efficiency difficult. However, consistency across all trials shows that therapy is effective in a significant portion of men with metastatic prostate cancer who have extinguished all other forms of treatment. In a review of current literature conducted by Emmett and Associates, 30 to 70% of men experience a greater than 50% reduction in PSA levels, while 10 to 32% of men with progressive disease do not respond to treatment. This image shows a 77-year-old patient with metastatic castration-resistant prostate cancer before images A to C and after images D to F therapy. Because of the progression, the patient was referred for 3 cycles of lutetium PSMA therapy. The PET-CT scan in images A to C demonstrated significant PSMA positive nodal metastases at baseline. A reduced tumour load was seen after 3 cycles of therapy. In a single-arm, single-centre phase 2 study of lutetium-177 PSMA therapy conducted at the Peter MacCullen Cancer Centre in Melbourne, of patients who had pain before therapy, which was 90% of participants, all of these patients had pain improvement at all time points, both in severity and interference with daily life. Additionally, they recorded rapid and clinically meaningful improvements in quality of life. The image above shows a 74-year-old patient with castration-resistant metastatic prostate cancer who had undergone previous chemotherapy. A PET-CT scan taken before therapy in December 2015 demonstrates extended pelvic, abdominal, and thoracic lymph node metastases. The total tumour volume measured semi-automatically is marked in red in the maximum intensity projection 3D image. After 3 cycles of therapy, the PSA level had significantly decreased and the total tumour volume had reduced, demonstrating a partial response. The patient further received 3 cycles of therapy and resulted in a biochemical complete response.
Bone is a major site for distant metastases, therefore imaging and therapy that meets the demand for pain palliation is required. Here are some radioligands that have been implemented so far. Summary. Currently, lutetium has been successful for the treatment of advanced disease. It's expected that we see more from alpha emitters, but there needs to be further study on well-defined patient groups and therefore established guidelines before this can take place. This takes time. As you can see, there is a multitude of potential radioligands that can be used and other therapy. The goal in the end is to have physicians and nuclear medicine technologists working together to create algorithms for these new therapeutic tools.